Close your eyes and imagine this. You're a surgical nurse in general theatre. It's the end of a long shift and you're scrubbed in for your last case. The surgeon has completed the closure of the surgical excision when you realise the instrument count is incorrect and the patient is now already in recovery. For a split second, time stands still. As the weight of what has happened sinks in, you feel your pulse racing, your hands are clammy, you have a knot in your stomach. What do you do next? Welcome to episode 16 of the All Ireland podcast series, Walk and Talk Improvement. I'm Selene Daly, Clinical Audit Facilitator with the National Centre for Clinical Audit in the HSE. I am thrilled to be joined by Teresa Donnelly, who is Director in the Centre for Nursing and Midwifery Education in Sligo, Leitrim and West Cavan. Teresa holds extensive experience in nursing to include perioperative nursing, operational nurse management, and nurse practice development. She is passionate about education, believing that the continuous education of our healthcare workforce is crucial to the strength and sustainability of our healthcare system. Furthermore, Teresa has acted as a mentor to many healthcare professionals in the Northwest, including myself, and I am honoured to call her my friend. Today, Teresa shares how she turned an incident in general theatre over 20 years ago into an opportunity for growth and improvement. She has since revolutionised general theatre practices, significantly improving safety and culture for both patients and staff. So, Teresa, you're so welcome to our podcast today, and thank you so much for joining us.
Well, thank you, Selene. That was a lovely introduction. So thank you very much. Yes, I am very dedicated. I love nursing. I've always loved it. I've always wanted to be a nurse. And I always say, going back years ago in the 90s, and I often speak now to the new graduates, in that it was very difficult actually to get into nursing in Ireland. And so I had to take myself off to the UK, which of course gave me huge experience. But I'm delighted that I've been back in Ireland for the last number of years. So I'm delighted to be here and I'm delighted to be involved in this podcast.
Brilliant. And we're delighted to have you. Now, I have had the pleasure of teaching with Teresa. I've had the pleasure of sitting in the classroom and being taught by Teresa. And there's one story in particular that just always made me sit up, maybe pay attention. And every time I hear Teresa's story, I learn something different from it. And I feel this story it's imperative that it's listened to by healthcare professionals across the board because it's just such an important story to hear. So, Teresa, can you take us back and just tell us what happened that day in particular when you were in theatre?
And I suppose, first and foremost, I've been very fortunate throughout my career in that I've worked with some amazing, dedicated professionals who always want to do the right thing. I've actually, honestly, never met anybody who didn't want to do the right thing. However, as we know, errors happen, and we know from the stats that the overall prevalence rate of error is over 12% of errors happening to our patients, and an awful lot of those could be prevented. So that's, I suppose, the background to it. And I suppose when I started my career as a nurse, I always worked to a high standard, and I would have always adhered to my code and to my PPPGs. And the reason I say that is, they always guided me, but sometimes, for whatever reason, it could be personal, it could be professional. Sometimes the system lets us down and we are involved in errors. And I suppose a number of years ago, I would never have thought I would be one of those people. However, it made me a better person and it certainly made me a better nurse. So the story I'm going to tell you about, and I suppose very common, and when I give this talk and I say to people, can you relate your current practice to that particular day and to what happened to me? And it's amazing how, as you said, people do sit up and they do say, oh my goodness, yes, absolutely. So it's over 15 years ago and it was in July and it was a Friday. And the reason I say that is I can remember quite vividly because with mistakes, and we talk about the second victim, and our priority is always our patient. And when something goes wrong, we all go into overdrive to make sure that our patients are okay. Sometimes we forget about the people that are involved in error, the good people, which the actual evidence would show that it's always the really good practitioners that actually are involved in the most serious errors. Mm-hmm. Yes. So I suppose to give the background, I would have worked in general theatre, even though I would have had experience in all the different theatres, but general theatre was the one that I was most passionate about. I was very fortunate in that I could job share because I had young children. So going back, all those years ago, I was working general theatre. It was a Friday, which was always the busiest day in theatre in the particular hospital that I worked in. The surgeon that I worked with was young, dynamic, had come, he was full of energy. He packed his lists. One of the best surgeons I probably ever worked with. I highly respected him, but it wasn't for the faint-hearted. You had to be on the ball to work with him. Yeah. I worked with him since he started in the hospital. And again, the reason I say that is I suppose sometimes become complacent. We get familiar. So I always like to talk about maybe the human factors that lead to error. So it was a Friday. We had a big list to do. As usual, there were job sharers on duty. That was usually the run of the mill. So we had a very busy list on Friday, came on duty. I knew we were going to have a busy day. We were short-staffed. The day started on a rush in that the surgeon had already indicated at the very beginning that he had to be in a certain place at a certain time. So for him to be there, he would need to have to be leaving by 5 p.m. So we knew from the beginning we were on a rush. So as was custom and practice, and I suppose I talk about cultures, it was just the way it happened. Not always would we have a manager on Friday. We would always have reduced staff. It would nearly always be job sharers that were working on a Friday. And then come maybe 4 p.m., most people were going off and it would be left to whatever staff, the job sharers possibly, or whatever, to finish up, because normally after that time we would just have had emergencies. So that would be normally the run of the mill. So I scrubbed for most of the day, and I would have scrubbed for most of the major cases. And, with that comes, you don't really have time for breaks, and you have to be, it's quick turnover. So our last case of the day, the patient went on the table at 1 p.m. And I suppose I remember this so vividly because I talk again about the second victim. When things go wrong, you remember every fine detail. And anybody I've ever dealt with or anybody I've ever supported through an incident, they can remember every detail. They can remember what people were wearing, what they said. So we were scrubbed at 1 o'clock. It was a difficult case. There was certain things that we did in theatre, I suppose, that would be out of the ordinary, that wouldn't be normal. Most staff had gone off duty by 4, so there was just 2 of us left. We were very short-staffed. The surgeon got into difficulty, possibly maybe about 4. And when I say difficulty, in that he was trying to access the tumour, so it meant that we had to open the chest wall, which again would not be normal practice, and we'd be using equipment that we wouldn't normally use. So we opened the chest wall. So bear in mind, we were all cognizant of the rush. Yes. At this stage, it became evident that the surgeon was not going to be where he was supposed to be. And I suppose everybody wanted to do their best for our patient and that surgeon. That was certainly his objective. So it came to, we eventually managed to secure, there was a particular tumour that had to be removed. We managed to be able to secure that, and it was coming to closing the patient. So, and I suppose to put it into context, for most abdominal surgery, you would have large swabs, they're called 45 by 45s. You might have 40. Yes. And the small swabs then that you can use 10 by 10s. However, they wouldn't be recommended in the abdomen. But again, there was nothing there in the guidelines to say you couldn't use it. So surgical preference. So, and then sutures. So we had 60 large swabs, we had 130 small ones, and we had 168 sutures.
Oh, Teresa, every nurse who's ever scrubbed their hair is to stand the back of their neck. Just to say, the sights, the sounds, the smells, you're just giving us that whole picture. It's the reality on the ground.
Thanks, Selene. Yeah. So then throw into the mix that we had extra instruments. So we would have had maybe, and if anybody that's familiar with theatre, we probably had possibly 6 sets. And if you were to break it down even further, you'd have had over 600 instruments. Yes. So, and again, I talk about the rush. So the surgeon and I was trying to, as the scrub nurse, keep on top of all the different needles, swabs, and I suppose the instruments. Yeah. So the surgeon asked for the closure, and I knew I had accounted for all my swabs and my needles, and I was doing my instrument checks. But again, pressures maybe. And in them days, I suppose, you come in, you're very cognizant that your job sharing maybe, and I like to think things have definitely changed. They certainly changed when I became the manager in, that, and I'm not apportioning blame to anybody. It was just maybe just a culture. So the closure happened, and I was aware at this stage then, I feel I haven't seen that particular instrument. So for people that work in theatre, it's called a mosquito, and it's like a small little clip. Now, it's not like a mosquito as we know a mosquito, but it's the instrument is called a mosquito, and it'd be like a small scissors, Selene. So I became aware then that I was missing a mosquito. But at this stage, the surgeon had finished the closure, had left the room. The patient was still asleep, and the anaesthetist was going to wake the patient up, was going to transfer the patient to recovery. So, and I suppose human, and again, I talk about human factors, and I thought, okay, I was tired, I'd had a long day, I needed a drink, I needed to go to the toilet, but I thought, no, I need to find everything before I do any of that. So, you just get that awful sense that there's something not right. So I knew I had all my needles, I knew I had all my swabs. So I started going through all my sets, and then I realized I was missing a mosquito. And my gut, inside of my gut, I thought,
turned upside down. Yes.
Yeah, absolutely. So I went out to recovery, and I said to the anaesthetist, don't transfer the patient over yet, because we're looking for an instrument. And he said to me, oh, it's probably in the rubbish and the linen. And part of me thought maybe it is. It possibly is.
Please God. Yes.
Yeah,
I know,
exactly.
I know.
But that old gut instinct. So I went back in again, and because we were short, and I was coming towards the end of the day, and I went through the rubbish and I went through the linen. So then I thought, I have to stop the surgeon from leaving the department. And I suppose that's where I say to people, our policies, protocols, procedures and guidelines, and our whole risk management process, which clinical audit is part of, is there to protect not only the patient, but ourselves. So I went out to the surgeon, and he was irate that I had said to him, I believe we're missing an instrument. And he said, same thing, it's probably in the rubbish or the linen. It nearly always is. So I said, yeah, you're probably right. And then I thought, no, I can't let him leave. I can't let him leave. So I said, well, in actual fact, I said, the policy states that we can't let the patient leave the department till we find everything. So I said, you're going to have to come back in, and we're going to have to x-ray the patient. Otherwise, the patient is going to be here all night. So he did come back in. At this stage, the patient was sitting up, and he was awake, and he was a lovely gentleman. And we did, as per the policy, we x-rayed, and the instrument, unfortunately, was inside.
How did you feel at that moment, Teresa, when you knew the instrument was inside and it was a case of going back in again?
Do you know, Selene, I suppose my initial instinct was, we need to do the right thing. We need to look after the patient. That was my first reaction. So my reaction was, I need to be there to get this instrument out, removed. And the surgeon, there was full disclosure, and the patient was lovely. He was so delighted that his surgery had been successful, that his tumor had been removed. So at this stage, the night staff had come in, and they had said, you go home, Teresa, and we'll scrub. And we tend to do this when things go wrong. When we make mistakes, we tend to send people home or send them off. I'm so glad I didn't go home, because you go through all sorts of things. I was already going to do that afterwards. But at that time, I said, no, I want to do the right thing by my patient from start to finish, which, like I've said, most of the nurses I have ever worked with, are clinicians or whoever, they want to do the right thing. So I scrubbed again, and the instrument was retrieved, and the patient woke up and was out in recovery. The surgeon again went out to speak to him, and again he was just so relieved, and he was such a lovely man, as most patients are when there's disclosure. And he said, look, I'm just glad these things happen, mistakes happen. So I suppose from that, Selene, that's probably where, I went home, and I went through so many emotions. I remember feeling so bad, because I'd never been involved in a mistake. I remember being embarrassed. I remember being ashamed, and I was thinking, I'm from a small rural area. Like my family are so proud of me. Like
Yes.
my mother would tell everyone I'm the CEO of the HSE. Like, um, they're just so proud. So
Yes, of
yeah,
course.
so I started going through thinking, this is going to be God knows
People are
what
going to be
process.
talking.
Yeah. And
Yes.
I'm going to
People.
probably end up, all over the papers, probably going to get end up
Mm.
fitness to practice. I
Mm.
totally exaggerated it in my mind.
Yes.
And then all I kept saying to myself then was my patient was okay.
Hmm.
We identified it before he left the
Yeah.
theatre. So therefore, if anything had happened, the patient, or if I hadn't identified it or I hadn't spoke up, then I couldn't have lived with myself. So I thought, whatever lies ahead, I did the right thing.
Mm.
And that
Yes.
was what kept me going for the following weeks that followed. So
Yes.
I went back to work and I was off for a number of weeks because in them days, like if you did, if you were job sharing or you did nights or you did anything like that, you got extra time off. I happened to be off for 3 weeks. It was the most horrendous 3 weeks of my
Yes.
life.
Yes.
I just could not focus. And I suppose the one thing that struck me was the lack of support because nobody rang to see was I okay.
Yes.
Now that
Absolutely.
has changed and I've seen it.
Thankfully. I mean, Teresa, when you're speaking about your experience so far, what you were doing, in fact, was what we do now in terms of open disclosure and in terms of employee support. You're speaking about, we have to do the right thing. The patient is paramount. We have policies and procedures there for a reason, that to protect the patient and to protect us too. But that's actually intuitively what you were doing. But just like you said, you were at home for 3 weeks and nobody rang. And that feeling of isolation is dreadful. And the voices in your head, we use emotion. We use that emotion of, I feel terrible. I feel dreadful. This is
Yeah.
what I didn't sign up for this. Oh my God, what am I going to do?
Yeah.
And instead of using kind of the facts of actually what happened. So what happened then after, say, the 3 week spell? The patient was safe. It was sorted. Then what happened to you?
So then I suppose I went back to work and then there was the whole risk management process. I dreaded that because I'd heard so many stories.
Mm-hmm.
In actual fact, it was a very pleasant experience, if you could call it pleasant,
Yes.
in
Mm-hmm.
that I felt it was very fair. There was no blame, there was no name, no blame, no shame, which we now promote. So you're talking
Yes.
about 15 years ago.
Yeah.
The risk manager was fantastic. He went on to be, I suppose, a group risk manager.
Mm-hmm.
And he was, he listened to everybody's side. How did it happen? So I outlined how we started the day on pressure. There was maybe cultures that were in the theatre that were probably tolerated and accepted. There was no breaks. People hadn't had breaks. There was a lot of stress involved. It was a busy day. Friday was always the busy day of the week. We were short staffed. So I laid out how I felt or what led to the error. However, I held my hand up and said, at the end of the day, I gave the closure. I didn't
Mm-hmm.
follow the policies, protocols, procedures, guidelines. So I'm going to take responsibility for my role in this error, in that I was a contributing factor
Mm-hmm.
also.
Mm-hmm.
So whatever had to follow on from that, then that was fine. I was going to accept that because
Right.
I was just so relieved that my patient was okay. I was so
Yes.
relieved that I thought whatever has to happen now has to happen. So it turned out anyways that it was all a very, very fair, open,
Mm-hmm.
so I suppose from there, then I did a lot of self reflection and I thought a lot about, why on that particular day, why did I feel under pressure? Did I feel stressed? Why did I give the closure? Why did I suppose, steer away from the policy? And I thought, how can I improve myself? So one of the ways I suppose I looked at, and that's why I'm so passionate about education, is I thought it's time now for me to start upskilling myself and educating
Yes.
myself, because
Yes.
sometimes we're afraid to speak up, and maybe
Mm-hmm.
it's part, I find anyways personally, living in rural Ireland, growing up my generation, you didn't speak up, and
Yes.
you nearly had like an inferiority complex, Celine.
That's right. Yeah, that's right. And I think that's felt among nurses in general. There's actually good evidence, research-based evidence that shows that sometimes we can feel a little bit inferior. And just reflecting back on what you said about your meeting with the risk manager, and to be, well, we're talking open disclosure, full open disclosure, I've been involved as well with instances, near misses in an instant, and with that particular risk manager as well. And again, years ago, before we even started the open disclosure policy within the entire HSE, and it was, again, as you say, a positive experience. It actually wasn't a negative experience. There was no blame, there was no shame, it wasn't a witch hunt. We were spoken to with such respect. And I have to say, I learned a lot over my years as well. Because as you say, Teresa, the best can be involved in experience. It doesn't mean that you're a bad person or you went out to do any harm.
Mm.
It just does happen, and it's the way it's handled now, which is fantastic. So you, and funnily enough, and very timely, the World Health Organization actually launched a report recently looking at international safety, and education is a huge part of it. It's actually about educating our healthcare workers around quality and safety, and that's such an important part of it too. So what did you do? So you kind of did the 5 whys, probably the 10 whys, Teresa, about why it happened. So what was
Yeah.
your next move? What did you do then?
So I thought, well, how can I be more confident in my role, and feel more comfortable? And honestly, Selene, for me, it was knowledge,
Yeah.
and I thought, yeah, and I don't claim to know everything. And I thought the only way that I'm going to feel comfortable and that I'm going to be knowledgeable is if I educate myself. I was the old style, apprenticeship style. I would have done my theatre course in the UK as soon as I qualified. And there was probably just a bit of a gap there. I would have done all my mandatory training and all that. So I thought, no, I need to go a little bit further. So I suppose I caught the bug. I did my degree. And then from that, then I did a master's. And during
Mm.
that master's, there was a module on clinical audit and quality assurance.
Mm-hmm.
And the lecturer that was teaching it was a lady by the name of Mary Cook and
Right.
Evelyn McManus, who's still in St. Angelo's.
Oh, I know
They
Evelyn. Yeah.
Right, yeah, they were hugely influential in,
Brilliant women.
yeah,
Brilliant. Mm.
hugely. Mary Cook was so passionate about clinical audit. And when I first did the module, I thought, I think this is going to be so boring when I read the brief on it.
Yes.
But in
Yes.
actual fact, I thought the light bulb went on. This
Mm.
is how we can provide the evidence to show that we need to improve or change or even change a policy or whatever.
Mhm.
So that particular module was my favorite, along with the quality assurance. And I was chomping at the bit to do clinical audit. To be honest,
Mm.
Celine, I thought this is
Yes.
a fabulous way of identifying what needs improving, and for somebody to actually go through how you could actually do it and simplify it and break it down, even to me, I associated clinical audit with research.
Yes.
And I was thinking,
Yes.
oh, so out of my remit. So,
Mm-hmm.
but anyway, so I did the edge. Now, at this stage, I hadn't had the opportunity to do clinical audit, but
Mm-hmm.
it was always in the back of my mind. And I suppose,
Mm.
again, I talk about when people are involved in error, and there's a lot of evidence out there to say that, an awful lot of people drop out, Celine. They drop out.
Yes. Mm-hmm.
That say, no, I can't. This,
Yeah.
or
Step back. Mm-hmm.
or some people just go from day to day and they just exist.
Yeah.
Or then there's the
Mm.
whole element of people that will thrive, and they're going to say, well, I'm going to improve things and I don't want this to happen to
Mm-hmm.
anybody else.
Yes.
So I suppose I
Absolutely.
would have fallen into that category. So I went on and I finished my master's, and then there came the opportunity to become a CNM2 in theatre. And I thought, you know what, I'm actually going to go for that, because I
Mm.
think, because sometimes when you go further up the ladder, you can definitely influence
Can.
practice.
Yeah. Yes.
So I started in theatre as the CNM2 in 2011. And
Mm.
the first thing on my agenda was clinical audit on counting in
Yeah.
theatre. First
Yes.
thing, I
Brilliant.
had been
Yeah.
given the tools, I've been given the knowledge, I've been given
Yeah.
the information on how to do it. I thought, now I'm
Mm-hmm.
going to do it.
Yeah.
So I suppose that's, and from there I continued on then with the education. So, and I remember, that, and I often laugh about it now, at the time. And I often think about that particular day and those 3 weeks I would have thought were
Yeah.
probably the worst of my career. But
Yes.
when I reflect back on them now, they made me the person that I am today, and I wouldn't be here today only for it.
Yeah. It's great to
Um,
hear it. Yeah.
yeah,
That's great to hear it. Yeah. And definitely when you say clinical audit, Teresa, people often mix it up. You're right. People often think it's research. They think it's a stick to beat you with. They think it's
Yeah.
a huge, arduous process, but it's actually not. It's quite straightforward. We're measuring our care against best standards. If we find that we're not meeting those standards, we start off the quality improvement process as a team, and then we can re-audit again. So I think people often think it's just a solo run as well, which clinical audit isn't. You're involving that team. So when you did your clinical audit, you looked at practices within theatre, was that right? Against standards.
Yeah. So, of course, obviously doing clinical audit, and it's not hard to do clinical audit. It's not at all. So, and it had been maybe 3-4 years since my year, but it was still there. And I said, so I'm going to look at the overall. So I looked at what was out there. I looked at the policy, our local policy, to see was there any failings there. You'd have to do your background education before our knowledge share gathering before you actually do the audit to see that it might need to be audited. But anyways, I thought I'm going to look to see what evidence is out there. There's always guidance on something, Selene. People say I can't find the standard, or where do you find the standard? And
There's
buckets. Like you can go to the nice.org.uk. I found information there. I found information with WHO, World Health Organization, our own national local policies, our local guidelines, our own regulatory body. There's guidelines there for everything. So again, I looked and I said, okay, so this is my standard. I have my standards. So this is what we should be doing. So I'm going to see, are we doing it? So then you look to see like what would be a good audit. And I always say to people like, if it's going to improve as quality improvement, I was going to look at 30 patients, 30 cases.
Yes. Good sample. It gives you that indication of what's going on in the space. Yeah, absolutely.
And again, what questions am I going to ask? So I suppose for people that haven't got a theatre background, so I was going to look at what were the standards. The standards were saying that the count should be done before you start the surgery, before the first closure, before the 4 counts for major surgery, that it should be made clear that everything was correct and that the surgeon should acknowledge same. There should be, now what I couldn't find was timing for counts. So all the policies would say there should be adequate time left for counts. So for me, I suppose adequate time, how do you measure adequate time? Like we know you're very good at everything you do, Selene. So you probably could do a count in jig time, right? But new people starting off, maybe people getting familiar. Yeah. So I suppose I wanted to measure that. What could I say that you needed to allow for your big count? 6 minutes. So I was going to time that. So my questions were the counts done when they should have been? I suppose, first of all, I started off with, was it major, minor surgery? Were the counts done when they should have been? Was it highlighted that they were correct? Did the surgeon acknowledge that they're correct? How long did the counts take? And I suppose, was the paperwork completed? It's not wrote down, we didn't do it, as we know. So there was 6 simple questions. And again, you have to just tell people you're going to audit. Apart from anything else, it's manners and
good governance.
So I did say it when I was auditing. I didn't say exactly, but I did give information as to when, because I wanted to get a true reflection of what was happening. So I carried out my audit over a period of a month on 30 surgical cases. And then I analysed my data. At the time, I suppose I wasn't aware that there was a clinical audit support team in the hospital, which most people aren't aware of.
Most people aren't aware of. And it is different from hospital site to hospital site, or now community site to community site. And then, well, as they're called, CAST or community or clinical audit support teams, they are wonderful at supporting. And the really important thing to do is to fill out what we call an audit proposal form. That's the key to actually getting that framework of what you're going to do from a governance point of view. But that sounds exactly, we're talking now 15 years ago, Teresa. So we are, things have improved, thankfully. So when you got the results of your audit, what did you find?
So what I actually found was that we weren't adhering to best practice. So the counts probably were, looking back on it now, were being done when they should have been done. I suppose one finding that I had was that, people were saying swabs, needles and instruments are correct, but sometimes they weren't saying it loud enough. Sometimes the surgeon wasn't acknowledging it. So that was the first failing. I suppose the other thing that I found was that it could take some people up to 10 minutes to do the big count. So that they were the key findings, Selene, and sometimes the paperwork wasn't as it should have been.
Yes. Yes. And then when that happened, how did you go around to make the change, as in the quality improvement process? How did you find that process? Did you get resistance? Was there an issue with culture within the space, or how did you manage that?
Yeah. So I suppose the first thing, and again, like I said, most people, it's how you sell it, probably, the quality improvement. And if people see that it's protecting themselves and their patient,
Yes.
um, so the first thing I did was I disseminated the findings, and I actually, anywhere I was able to broadcast that, I did that. So I disseminated
Yes.
them within the department initially to all the staff there, and it's
Mhm.
amazing how when people hear it or when they see it in black and white, they say, "My goodness, that's me," or "That could be me," or
Mhm.
"That's I can see."
And you know exactly what you're talking about, like going back to, and this is bringing me back down memory lane now, but you know, we often work in teams and we get so used to working with each other, you almost don't have to speak or feel like you don't have to speak to each other. And that space that Teresa's talking about in theatre, you actually have to raise your voice, and that can be really difficult for some people, whether it's their background, you know, their own life experiences, their self-confidence, to actually ask somebody, can you confirm that I have said this, or that you have heard this, or can you confirm the count? And that can be really difficult for people to do. And we can fall into these, what's often called as silos, where we're working in spaces where we are almost communicating without words, which is not good either. And as you say, Teresa, it's only when somebody shines a light on that and says, well, we have done an audit and we found this. And again, not a stick to beat anybody with, just to highlight that the practice may not be meeting the standards that we want. And again, in theatre, I know now we have our safe surgical checklist, which is brilliant. There's a whole new tool along with that. So this is, again, we're going back in time a little bit. But certainly the culture of that, just being able to say, well, look, we've done an audit, everyone's involved, here's the findings. It's not a stick to beat you with. We can do some great stuff here and make some changes. What changes did you make in the theatre space then?
And we actually did, Selene, like, and when people saw, and then I presented it to the surgeons. So it was great. We had this lovely audit. We had these findings, which were very significant. We had disseminated, we had raised awareness. People were more conscious of the findings, but that's just not enough sometimes. In the, how do
Yes.
you sustain that then? So then I thought we need to look at the local policy. So you can, information sharing is crucial and educating people, but then you need to look at firming that up, and that's through the policy. So we reviewed the policy for counts, and we put in a line, a simple one line, that closure would not be given or until swabs, needles, and instruments were correct and the surgeon acknowledged same. That, I suppose, was just key in that. Then we also put in like about timing. Counts can take up to 6 to 10 minutes. You know, for the big count, not all
Yes.
counts. But I
Yes.
suppose there was something then that people could think, absolutely. So we can't be rushing people. We need to allow this time. So it turned out to be a very successful change. And I have to say, I worked quite happily as the CNM2 in theatre from there on in for the next 4 years. And we never had a counting error again in my
That's
time
amazing.
there. And
Yeah.
recently I spoke to people in theatre, just recently, and I spoke and I said, have you ever had an incident when I was going doing this podcast with you, Selene, I said, have you, since I've left, because I'm a number of years gone now, have you had any retained instruments? And they said, no, absolutely not.
Yeah,
And
because that was embedded within the culture of the space, that you proved that there was a safety issue, and that just one simple line in the policy that everyone's going to adhere to as a team. Do you think that now Teresa will not blow her own trumpet here, but I can tell you, Teresa has done so much quality improvement in that space, all kinds of various things. And I remember walking over to Teresa's office one day and she had a little car, a little toy car behind her, because there was a quality improvement piece, I think you did, Teresa, about children going to the theatre space and feeling nervous, and they actually had funding to buy little cars to bring the kids to theatre in. And then we're thinking, well, this woman is unbelievable, and what she can do, it's amazing. And the small little things that you've done as well within your space when it comes to quality improvement that have made a big difference. Do you feel, and I know the answer to this because I know you and I know your colleagues from years ago, but do you feel that that point of doing that clinical audit, of starting that whole process off, do you feel that changed the culture within the theatre space at that time?
Absolutely, Selene, because we went on then, and I say we because it's all a team. I did that piece of work myself. People embraced it, they embraced the change. They needed support to embrace the change because they were a bit nervous about speaking up, like you've said. And
Mm.
there's several ways, and I talk about, can you change behavior? Sometimes not, but you can change how you react to it. So we went on then, and we had the bug as a team. This is great. We can improve practice by our clinical audits. And again, I felt strongly about it because it was, I suppose, so significant. And I felt I never wanted anybody to feel what I felt that day or for the 3 weeks after or for a long time afterwards. I actually went on then, I presented it as a poster at a national conference, and I actually won best poster. Then I
Yeah.
was invited to speak in Rome, and I
Mm.
won best speaker. From
Yes.
that, then I was invited to speak in Los Angeles. Imagine, so I said, my little clinical audit in the northwest of
Yes.
Ireland brought me
Yeah.
all the way to LA. And,
Yes.
and it was amazing how people in that particular international conference, there was people from all over the world. And I remember one person saying to me, but Teresa, you followed the PPPGs, albeit a little bit too late, but we're dealing with cases where patients have left the theatre or they've come back in or there's been stuff found at post-mortem. But I said, and I said, God, that is shocking. But I said, honestly, that particular day, it had the same impact on me because I felt I'd failed myself. So from
Mhm.
that then, Selene, I suppose, so that's my little audit brought me all over. I also got it published because I wanted people
Mhm.
to dispel the fears of clinical audit. So I got it published. So I went on then to do several other audits, and we did them as a team. We looked at different areas that we could improve practice. Actually, one of our audits, we actually again won best innovation. It was called the Red
Right.
Zone. And again, that was all interdisciplinary, multidisciplinary, everybody involved, because
Yes.
when people see it's going to improve things for them, and most certainly for our patient, 9 times out of 10, people will come on board. And we know the whole change
Absolutely.
process, and like I always
Absolutely.
say to people, and I talk, and every year I'm asked to give this talk to the postgraduate nursing students in University of Galway. And,
Mm.
I suppose I love that saying that Donaldson says, you know, terror is human, to cover
Mm.
up is unforgivable, but to fail to learn is inexcusable.
Hmm.
I think that's
Yes,
so powerful.
absolutely. It
And
is so powerful, so
yeah,
powerful. And I think over the years, sometimes you can be so afraid when that happens. When you were speaking about the way you felt, it's physical symptoms. It's sweating, it's stomach churning, it's indigestion, it's your body is literally turning itself inside out, and you would almost dig a hole to throw yourself into. It feels so bad. And when we're working from emotion in that way, that's when things start to get out of control. It's when we work, as you say, with the PPGs in, I suppose, an organized way that we can promote patient safety and quality. When you were speaking, Teresa, really, I think people listening they're just going to connect with you. Anyone who's ever worked in the theatre space, particularly, I remember as a student nurse in orthopedic theatre having the lead apron on for hours on end. And if anyone listening doesn't know what a lead apron is, it's when you work, particularly in orthopedic theatre, you have to wear this, what they call lead apron, front and back, to protect you because there's x-rays continuously going on within the theatre space. And it literally weighs, I would say, a couple of stone
yeah,
for
yeah,
adult people, but a couple of stone on your back. And there's often a saying as well about the nurse's bladder being so strong because we just don't use the bathroom
yeah,
for a full 12-hour shift. And
yeah.
that's not human either. And, often we can find ourselves in situations where we are tired, we are fatigued, we are emotionally drained. And something that you said as well, and it's important that we be able to use our voice to say this isn't okay, that we do need a break. And the other thing that you said was, well, that feeling that you had, there's something about gut instincts. There's something about, your intuition that's really important as well as a healthcare practitioner. And I know on the I'm News record, we're talking about Pews or I'm News or the early warning scores, there is that piece at the end, you can take your blood pressure, your pulse, your temperature, but if your instinct is telling you something isn't right, that you have to follow that too. And I think that's really, really important as well. especially when we work in spaces where
Mm,
it's not planned. So,
yeah.
emergency theatre is completely different. ED departments, we're working in
Mm,
spaces where care is not scheduled. It's not like you're getting on a flight and there's 300 seats and everyone's got their ticket. It's completely different to that sometimes. And we
yeah.
have to use our instincts in properly along with our PPGs and everything else as well to make sure we're delivering safe care.
And I
But
suppose, Celine, just on that too, like
mm,
when I look back and I reflect, like sometimes we make assumptions. So
yes,
when do errors happen? Revisited that so many times. And like
yeah,
I'm pragmatic. I can't say, and I used to always say that, I can't say that I'm never going to make a mistake again. Nobody can say that because, but I knew that after that, I was never going to make that mistake again. And I was going to
hmm,
try and protect everybody around me. But we make
yes,
assumptions like I can look back now and I can say we have become maybe a little bit complacent in that the surgeon was familiar with me, I was familiar with him. Yeah, the environment, like it's nearly when I went on to become the manager, like it was nearly a case of, well, Teresa's just in one day a week, so she can do that,
yes,
or,
yes.
you know,
Some assuming that, and there's always that good person. I know there was always that good person that'll cover all the shifts.
yeah,
That you ring that nurse, she'll definitely come in. And there's it's so important that we're respectful of everybody that we work with too in the environment, that they can come and talk to us as well in an open way, that we're not assuming that somebody's competent in something, or we're not assuming that they're just okay with doing whatever is dictated in the space that we do. I was at a recent talk, it was fantastic, and somebody from the UK actually was talking about the idea, or the concept of not competition but co-petition, in that's what you were speaking about as well, Teresa. It's that you want to share this audit that you did, the findings with everybody. It was a group effort. It wasn't just one person. I think often we leave people out of the environment that we're working within in hospitals. And, we are nurses, you and I, but we are working as a team with
mm,
medical healthcare professionals, speech and language therapists, physios, radiographers, radiologists, everybody. And also we often forget, and something that I'm passionate about is like our grade 3, 4s and 5s, people
mm,
who are keeping our notes safe, keep
mm,
people who are, filing away our precious documentation, as you were
yeah,
speaking about. That's so important that we can retrieve, that is accurately kept and secured, and that we are all working as one team
mm,
within the HSE, to provide quality care and to provide safe care for patients as well. So a team effort is really, really
yeah,
important. That's why I love clinical audit. Just like you said, Teresa, it's not complex. It doesn't have to be complex. We've lots of tools now we can use, like we have a practical guide in clinical
mm,
audit on the National Centre for Clinical Audit's website. We have Excel templates. We have a toolkit for clinical audit. We've got GDPR guidance and advice. So we have lots now that we didn't have before
yeah,
that we can use to do clinical audit, and it doesn't have to be complicated. And we are there to help for the National Centre for Clinical Audit as well. So, anyone can contact us at any time, and we can assist if
yeah.
it's something like I can't find a standard or I don't know where to start. And we do provide education and training, as I know you do, Teresa in the CNME in Sligo, Leitrim, Cavan, is always providing education across the board on everything nursing, but for everybody. Every HCP is out in that CNME getting education on clinical audit, quality, and a whole host of other issues as well. So if you go along to HSE Land, you'll see Teresa's offering there on HSE Land as well.
And I do think it's important to say as well that I love that saying. I was a colleague of mine recently said it, when we work together, we should learn together. So
Absolutely.
therefore, we have to learn together. Like, so it's important. That's
Yes.
why I open up all education to all of our colleagues. And I suppose, again, just on that too, about the assumptions. When I went on to become the CNM2, like I didn't come in and assume Selene Daly was going to do a
Every
scrub,
Monday. Scrub every Monday.
whatever. So
Yes.
I used to come in
Mhm.
and I used to say, what do people feel like doing today? Because like most people are very good willing. They're not going to try and skive off.
That's
I
right.
rarely met people that tried to skive off.
Yes.
But just to move away from that assumption that,
Mm.
because on that particular day, like when you go back and you take the human factors, I probably didn't feel like scrubbing all day,
Yes,
because I had a
absolutely.
lot going on, like when you have kids at home and you have different things going on.
Yeah.
So, even just, I think just to be aware of your team, to be cognizant, like what would you like to do? Now, that said, I've been very fortunate in that I've worked with the most amazing managers that,
Mm.
the manager in the theatre was so encouraging at the time, the director of nursing, my
Mm.
current management. I'm very, very lucky in that
Yeah.
I've been able to support people in
Yes.
developing themselves. So I do
Yes.
think, like you said, Celine, clinical
Mm.
audit, don't be afraid of it, embrace it. It protects not only the patient, but ourselves.
Yes, and in particularly for, I think, around nursing as well, because my background would be CNS specialty. And the one question we always said was, how can I prove what I'm doing is safe? How can I prove what I'm doing is quality? And that I'm earning my money, basically? Because often within specialities, as in I was in dermatology and neurology, you may only see two patients on a particular day in the morning on a schedule, but those two patients could take you literally an hour and a half to 2 hours each to
Mm,
see. But you are keeping that person out of hospital. You are keeping that person alive in some cases. You are increasing that person's quality for life. And clinical audit, so you've only seen two patients in the morning, but it's actually things like clinical audit that can show that you as a practitioner are, saving money, providing safe care, providing quality care that can be compared against standards. And I used to say to my patients all the time when I was doing clinical audit within my space was, I can show you that the care that you get within the hospital that you're in at the moment is the same as the care you get in
mm,
Dublin Hospital, it's the same as the care in the London Hospital, it's the same as the care in the hospital in France, because we're all using the same standards.
yeah.
And that's really important that our patients, our service users know that as well.
Mm.
I think this conversation has been fantastic, Teresa. I think we need to do some more podcasts with you. I think there's so much you have to say. And I think the power of storytelling is so important. I think
Yeah.
people really connect with that and connect with you. So, Teresa, thank you so much. It's been such a pleasure to have you here today to talk, and hopefully, we're going to talk again very soon.
Thanks, Celine. And I suppose my parting comment is always do the right thing. Don't be afraid to speak up, even if it goes wrong. Please speak up. Another very good colleague of mine, and we do meet people that influence us through our careers and through our lives. And she always says, follow the process, follow your PPPGs slavishly, is the word she uses.
Yes.
So, my final comment is don't be afraid to do your clinical audits and follow your PPPG slavishly. And thank you, Celine and clinical audit team. I'm delighted. I know you do provide education for us, so I'm delighted to call you my friend also.
Thank you, Teresa. As we come to the end of this episode, we hope you have found Teresa's story inspirational. I know I certainly have. We can all relate to the panic that arises when an incident occurs, the physical symptoms that manifest, like feeling your heart racing, and it can be absolutely terrifying. What I will forever appreciate from Teresa's story is firstly, she did the right thing for the patient. Secondly, she took this incident and used it to make things better for patients and all healthcare workers. And thirdly, she didn't quit, but used this incident to thrive. I hope this episode demonstrates that clinical audit doesn't have to be an arduous task or something that's out of your reach. It's a resource and tool for improvement. Teresa utilised the clinical audit to revolutionise safety and culture with surgical theatre. How can you use clinical audit for improvement? All of our resources are available on the HSE National Centre for Clinical Audit website. Stay tuned for our next episode with Jerry Clerkin, who shares his insights on quality and patient safety improvement and governance throughout his career in healthcare. This episode was co-produced with Selene Daly and Sheema Lughmani, HSE National Quality and Patient Safety Directorate. Thank you for listening.